This has got to be the most recognizable rhythm in medicine, Torsades de pointe. And most people think they know how to treat it, but they're wrong. Here's the data for you. Everybody knows you give magnesium for torsades, but nobody seems to know why they're giving magnesium for torsades. I'll give you a hint. It's not to terminate it or to correct the QTC. Let's talk about it. My name is Ryan. I'm a clinical toxicologist and emergency medicine pharmacist who works in emergency departments to help treat things like arrhythmias. And I love talking about two things: poisons and electropharmacology. And I am all out of poisons today. Torsades is a perfect example of something that really bothers me in medicine, where we give a drug because we know we're supposed to give it without actually understanding why. And I think Torsades actually suffers from this more because it's a really identifiable rhythm and there's one treatment. Everybody learned the one treatment, so when you see it, you give it, but you don't know when or why you're giving it. So to combat that, today I'm going to explain exactly how magnesium works, exactly how Torsades happens, and why magnesium has any impact on it. Hint, it's actually not to terminate the rhythm. So if you want to learn why you're doing things, let's talk. Fair warning, I know a lot of my viewers are not in medicine, and I often try to keep the concepts understandable enough for anybody to follow along. This is a more complex topic about a niche disease state in medicine, so I am going to go a little bit more in depth to the degree I go to with medical learners. So it's going to be more complicated, but I will try to make it so everyone can follow along. And if you like the kind of depth you find in this video, let me know, because I can make a lot more like this. Okay, to understand this, we actually have to understand action potentials, so I'm going to talk about that briefly. Look, if you put salt in a solution, it dissolves to spread out equally throughout the container. But that's not what happens in your cells. In your cells, you actually have ions sequestered in specific areas of the body, intracellular and extracellular. The reason for that is because today you made somewhere between 30 and 80 kilograms of ATP to power this pump, a sodium-potassium ATPase pump. It requires energy, it pumps sodium out of the cell and potassium into the cell. The amount of sodium going out is always more than the amount of potassium going in, so you always have more positive charges outside the cell, which means the inside is more negative. If you stick an electrode between the membrane, you can measure the relative difference in charge, and we actually find that it's about negative 90 millivolts less inside the cell. That's what we call our resting membrane potential. And being negative inside means it is polarized, it's got a charge, and if we're polarized, we can depolarize, and that's a really important thing to do. We can open up sodium channels, which allow all that sodium to flood into the cell, and I go from negative 90 millivolts all the way up to about positive 10 millivolts, and this is great because it kicks off all the secondary messengers that lead to cardiac contraction. After those sodium channels open up, all the potassium that was in the cell is like, oh my gosh, there's way too many charges in here, and it starts to leave the cell. So you see we go all the way up to positive 10, but then we start decreasing, and that's because potassium ions are leaving the cell, and they're also positively charged. But the really important thing that happens when sodium enters the cell is that calcium channels open up. These are voltage-gated calcium channels. They only open when the cell becomes positive. So even though everyone gets really excited about sodium depolarizing cells, it's honestly the roadie, the real band, the player, the star of the show is calcium. It comes into the cell, binds with tropomyosin, allows actin-myosin to form a cross bridge and contract. That's how you get a cardiac contraction. And when we look at it on an action potential, we actually see a flat line. And that's because calcium is coming into the cell while potassium is leaving the cell. This is the most important part of the video. Please listen. We have a flat line here because we have an equal amount of positive charges leaving the cell, potassium, as positive charges entering the cell, calcium. If that equilibrium is disturbed for any way, we no longer have a flat line. That will come into play. Now that all of that has happened and my cardiac cell has contracted, I need to reset the process so it can do it again. If your heart only beat once, you would die. So the way I get my cell back to its resting membrane potential is by potassium leaving the cell. So this is called repolarization, or phase 3. So sodium in, open up the calcium channels, potassium's leaving, calcium's coming in. Then your sodium and calcium channels close so no more can enter, and potassium leaves the cell, allowing the cell to repolarize. That's what you need to remember. So this action potential is occurring in your 2 billion heart cells each and every time they depolarize and contract. And what's beautiful is each time one cell depolarizes, it depolarizes all the ones next to it. And it's spreading from the atria to the ventricle and contracting all your atria and ventricle. If you imagine this background is the myocardium, each depolarizing cell depolarizes the next one after it, and then they repolarize. As you see, they turn white again. Okay, that's the basics, and understanding the action potential is important. But now let's talk about how Torsades initiates in the heart and propagates. It's actually two different things. Our best evidence suggests that Torsades comes from an early after depolarization. Let me show you. Here's my depolarizing wave moving through the ventricles and early after depolarization. It is an ectopic beat from a cell that was too excitable and set off all the other cells around it. It's actually not that big of a deal usually. We see these as PVCs on an EKG. But what actually sets an EAD off? Okay, let's look at an EAD on an action potential. Remember, sodium depolarizes the cell. Then potassium starts to leave, but as calcium comes in, we remain flat. But what if you actually block potassium's exit with, say, a drug that inhibits potassium channels? Well, then you're not going to have as much potassium leaving, and you have the same amount of calcium coming in. You actually start to become more positive in the cell, and you get an early after depolarization. So drugs that block potassium channels actually predispose you to developing an EAD, which can be the trigger for torsades, not always. The EAD is the trigger. It's like a lit match. If you throw it into a wet field, you're not going to get a wildfire. You need the right substrate. Here's an example. Remember, here we have an early after depolarization causing a PVC. Nobody goes into torsades. So what is special about PVCs in the setting of potassium channel blockade? Well, it turns out blocking potassium channels and delaying repolarization not only predisposes you to early after depolarizations or making more of those lit matches, but it changes the cardiac substrate from a wetland to, let's say, dry tinder that can then propagate the arrhythmia or the wildfire. Let's show you. Remember, potassium leaving the cell is what's responsible for repolarizing those heart cells. Here's an action potential with potassium channel blockade, and you can see it delays or prolongs repolarization. So that's for every cell in the heart. Let's see what that looks like when each cell now has a longer refractory period. Here's your normal ventricular myocardium depolarizing. You have a depolarizing wave, and lagging behind it you have cells repolarizing, but it's largely pretty uniform. There's a little heterogeneity, some repolarize slower than others. Now let's add potassium channel blockade. Wow, we have a lot of big splotchy patches back here of cells taking a really long time to repolarize because we have blocked potassium channels, so it just takes them longer. And because you have natural variation in your heart tissue in terms of how long it takes to repolarize, you get these little chunks. Our substrate is now different, and that's a big problem in torsades. Because while torsades may start from an early after depolarization that it's more likely to have because of your decreased potassium currents, it actually propagates through a re-entrant rhythm. This is the same mechanism that SVT propagates around. Imagine this red dot is refractory tissue. When an EAD goes off, it can actually propagate around that tissue using it as a locus and then depolarizing everything else around it all the time. So this is a way too fast rhythm. It's problematic, and it's depolarizing everything else. Now remember, in normal cells, we don't have those little islands of repolarizing tissue. So when an EAD goes off, there's nothing for it to circle around. But when repolarization is prolonged via low potassium or potassium channel blockade, I get these islands. And then when an EAD goes off, now I have all of these little refractory islands for my rhythm to propagate around. You are witnessing torsades right now, moving around all these different foci, which are just refractory tissue it can propagate around. So mechanistically, potassium channel blockade leads to two hits, which causes torsades. The first is the predisposition to early after depolarizations, the lit matches. The second is the change in the myocardial substrate where the lit match is going to get dropped, turning your ventricle into dry tinder. So when an EAD does go off, you get these twisting of points, torsades. And that is where torsades gets its characteristic morphology of twisting points. Each QRS seems to be different from the QRS after and before it. Even though you're looking at the heart from the same angle, the origin of depolarization is changing with each heartbeat as that disorganized rhythm finds a new area of repolarizing tissue to propagate around. Okay, that's initiation, which occurs from early after depolarizations that are more likely to occur when you've blocked potassium channels because it allows calcium to come into the cell at a rate faster than potassium is leaving. And propagation of that EAD occurs when I have areas of refractory tissue that can act as reentrant pathways for an early after depolarization. So let's talk about treatment. Every time someone sees torsades, someone runs off to get magnesium. But the treatment for active torsades is not magnesium, it's electricity. Remember, stable, medicate, unstable, electricate. Magnesium, as we'll learn, is not designed to terminate torsades, but electricity is. And these patients are usually not stable. If they have a pulse, they're usually not conscious. So electricity is definitely warranted. Let's actually take a look at the impact of electricity on torsades. Okay, here is our EAD, starting to propagate torsades, and 1, 2, 3. Defibrillation. By making all the cells refractory at the same time, you terminate the rhythm. Honestly, it's probably faster than getting magnesium into a patient anyways. Now, has magnesium been thought to terminate torsades? Sure. In a 1988 case series, they gave mag to 12 people, 9 of them converted. But I've actually seen several cases of torsades, and many of them terminate on their own, no matter what you give them. So assigning the credit to magnesium is difficult because rhythm, and if this EAD doesn't find enough of refractory tissue patches to run around, it just stops. Where in all this mechanism have we seen how mag would somehow shut down a bunch of refractory tissue? But magnesium does play an important role. It is in preventing and suppressing further episodes of torsades. So after you shock that person, you should absolutely get some mag in them, regardless of what their serum magnesium is. And that's because it prevents early after depolarization. Remember, we have an early after depolarization because our calcium current is stronger than our potassium current that's leaving the cell. So one way to weaken the calcium current is to put a divalent cation that looks like calcium right into the calcium channel so that calcium can't get there. And that divalent cation is magnesium. Magnesium looks like calcium and acts like a calcium channel blocker, suppressing the EADs that initiate torsades. This is also why calcium channel blockers have been used to prevent torsades. It's also why in the AHA guidelines about management of torsades, when they talk about drugs that prolong the QTC, they note that amiodarone rarely causes torsades to point. And that's because amiodarone has a built-in calcium channel blocker. So magnesium is to suppress torsades. And that's why in the 2017 AHA-ACC Rhythm Guidelines for Managing Ventricular Arrhythmias, it notes that patients who have QT prolongation and recurrent torsades should have administration of IV magnesium to suppress the arrhythmia, not to terminate it. This is also said verbatim in the 2018 American Heart Association Focused Update on Advanced ACLS and Use of Antiarrhythmic Drugs During and Immediately After Cardiac Arrest. Magnesium is commonly used to treat torsades, although it actually acts to prevent reinitiation of torsades rather than pharmacologically convert polymorphic VT. Now, is giving magnesium going to hurt this patient? Absolutely not. But is it really the treatment we should be focusing on once we realize it prevents initiation and not necessarily causes termination? You should probably focus on something that will terminate the rhythm, like electricity. We should focus on giving magnesium when people are at risk for torsades. So remember, potassium channel blockade by drugs or low potassium prolongs repolarization of the action potential. We measure this repolarization using the QT interval as the most common method. Remember, the T wave represents repolarization on an EKG. So when I prolong repolarization on the action potential, I get a prolonged T wave. And a long QT tells me, hey, this patient might have those tissue conditions where they have heterogeneously repolarizing tissue that can act as a focus for an EAD to propagate around as a reentrant rhythm. One more really important thing, full disclosure, I'm at a dog park right now. I finished the video and forgot to add this piece, so I came back to do this. Okay, a lot of people said you would give magnesium to correct the QTC. And that's actually not the case. You should not really expect to see the QTC get corrected unless they're hypomagnesiemic already and that was impacting their potassium. And here's why. Here we have the action potential and we can see how that aligns with a QRS-T interval on an EKG. Sodium depolarization represents our ventricular depolarization. While calcium and potassium are exchanging, we have no net movement of ions, so we're electroneutral. And then as potassium leaves the cell, we get repolarization. Prolongation of potassium leaving the cell prolongs repolarization. Where is magnesium in this? My QT is getting longer, or my T wave is getting longer, but at no point would magnesium impact this. We give magnesium to prevent the early after depolarizations that may occur when you're at risk because your potassium efflux is a lot slower. Magnesium does not correct the QTC. You can also have slow efflux of potassium if you're hypokalemic, and sometimes it's hard to reestablish your potassium gradient if you don't have magnesium, because magnesium is used by some of the co-transporters to get potassium into the cell. So sometimes you need to correct magnesium to correct potassium, but generally speaking, in a eukalemic, eumagnesiemic patient, giving magnesium is not going to correct your QTC. Okay, we made it to the end. I'm going to bet you know a lot more about torsades than you did before. I know this was a way more in-depth video than I usually go, but I also think it's good for people out on social media seeing healthcare workers put out digestible videos to get an understanding of the depth of knowledge that we sometimes go into in order to manage disease states. So if you like this kind of depth and content, let me know, because I can try to make more of it in this realm. If you are a healthcare worker and you learned something new about the QTC and torsades and magnesium, please leave a comment, let me know. If you got a hot take on this, let me know. Remember, it is fine to give magnesium, but you should also think about electrocuting people. And usually by the time you get back with magnesium, they're out of the rhythm anyways. Okay, this was a lot of fun, I guess, for some of us, probably, maybe. I'll see you at the next electropharmacology case review.